Hi, I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and Healthcare Can podcast serial where we dive into healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. Today, we're going to boldly go where many don't want to go, and we're going to have a candid conversation about palliative care. We're going to importantly discuss what part palliative care plays in care, and quite frankly, the life and death continuum, and why the palliative care approach is critically important to the conversation about both leadership and our health workforce as well. While many of us are deeply uncomfortable with any conversation about death, a conversation about palliative care is much more about quality and quality of life. Indeed, as you'll soon learn, the palliative care approach can be applied at any stage of treatment and diagnosis. It is also one of the best examples, when done well, of team-based care, which means there is a lot that other teams can learn from this discipline. All that said, palliative care is, for many, a poorly understood part of the care continuum. And again, as you'll hear from today's guest, palliative care has what he calls a brand problem, which has long kept it in the shadows of conversations. And being poorly understood means we also don't well include it in conversations about healthcare improvements and investments. Hopefully that changes for some of you who listen to this conversation. So for this conversation, I'm joined by Jeff Moat, the CEO of Pallium Canada since 2017. Jeff has 30 years of experience in creating organizational excellence, compelling social change programs, and increasing consumer engagement within the not-for-profit, private sector, and NGO industries. Previous to this, Jeff worked at the Mental Health Commission of Canada, where he established Partners for Mental Health, the country's first non-profit organization dedicated to accelerating a social movement to transform the way people think about mental health and act towards people living with a mental health problem or illness. Jeff also enjoyed an 8-year tenure as National Director of Marketing for the Canadian Blood Services. And before all of that, he spent the first half of his career in the financial services as Assistant Vice President for Citibank Canada and One Bank International, and later Vice President of Marketing for Alterna Bank. Jeff is a graduate of McGill University, where he received his Bachelor of Commerce in Marketing and Management Policy. Jeff holds a certificate in Finance and Accounting from McGill University and has earned professional certificates in Direct Marketing and Database Marketing from York University. Jeff also has his Chartered Marketer professional designation. So hi, Jeff, and welcome to the HQ.
Hi, Dale. Great to be with you today.
Yes, thank you for joining me today. And see, maybe, Jeff, what we can do about the brand problem that is facing palliative care. So maybe we can start there. Certainly, as we read from your bio, given your background in marketing, I believe you're very sincere when you say that the palliative care does have a brand problem. So perhaps we could start there. What is palliative care from your perspective, and when does it actually start in terms of care?
Yeah, thanks, Dale. It's a very important question. I do sincerely believe palliative care does have a brand problem. It's not well understood by most Canadians. It's not well understood by most healthcare professionals. But I agree. Let's start with the definition. So, palliative care encompasses a holistic approach to caring for patients and their families who are confronting life-threatening illnesses. Palliative care isn't just for those who are near death, nor is it reserved for those who are elderly or frail. Anyone who faces a life-threatening illness could benefit from the palliative care approach. The goal of palliative care, Dale, is to improve or maintain the quality of life and alleviate suffering by promptly identifying and addressing physical, emotional, social, and spiritual needs, helping people live as best as possible through their illnesses and to die better. It includes reflecting on what their priorities and values are for end of life. It's also about supporting families and loved ones as they journey with patients or residents in the case of long-term care homes. Palliative care should be initiated early and not only in the last days or weeks of life. It can be provided alongside treatments to control the disease, such as chemotherapy or radiotherapy, dialysis, and treatments to control heart disease and lung disease, for example.
Mm-hmm.
A crucial aspect of palliative care is its person and family-centered nature. It implies that individuals receiving care, along with their loved ones, are placed at the core of decision making.
Mm-hmm.
Palliative care should be seamlessly integrated with other treatment strategies and should be made available in diverse settings. We're talking home and community care, hospitals, long-term care homes, emergency departments, critical care units, among others, and provided by a wide range of healthcare professionals. And we're talking about, not just physicians, but nurses, nurse practitioners, pharmacists, social workers, paramedics, occupational therapists, spiritual counselors, and so on.
So yes, so it in itself, in terms of what you describe it encompasses the continuum of care and care providers. And I think you certainly, provide a picture that shows that it isn't something that happens, separately, that it happens in tandem with other parts of care, how it's administered and provided. Um, so, I mean, what is the struggle with it being understood and known? Like, I mean, what's getting in the way, and why aren't we talking about palliative care more earnestly and often?
Yeah. It's interesting. Back in 2014, the World Health Assembly, which is the decision-making body of the World Health Organization, it called on all member nations to integrate palliative care as a core service in their respective healthcare systems. And this resolution, I believe, highlights the need for palliative care across the continuum of care. In other
Mm-hmm.
words, early, right, and across different settings of care, and the palliative care approach. And it actually stated, and I printed it out here, it said, realizing the urgent need to include palliation across the continuum of care, especially at the primary care level, recognizing that inadequate integration of palliative care into health and social care systems is a major contributing factor to the lack of equitable access to such care. So Dale, to affect system level change and a culture change, a critical mass of healthcare professionals across the whole healthcare system, as well as the public and health policymakers and the public themselves, need to become acquainted with the palliative care approach and be able to apply it. So if you think about this, a patient with heart, lung, or kidney disease, for example, will not benefit from the palliative care approach if his or her specialist has not been oriented to the approach.
Mm-hmm.
That patient's family physician or home care nurse isn't able to apply the palliative care approach if there exists a discord between what the family physician is saying and what the specialist is advising, right? Training a home care nurse about palliative care is fruitless if the family doc views palliative care as giving up or only for end of life. So educating patients and families about palliative care is pointless if the surgeon or the intensivist or the cardiologist have a completely erroneous view of palliative care. So integration of palliative care across the health system and social supports networks, I should say, is paramount, and education of the workforce to provide generalist level and specialist level palliative care is a key requirement. There's a notable researcher by the name of Kevin Brazil, and he explains that the integration encompasses the amalgamation of administrative, organizational, clinical, and service components to establish a seamless continuum of care among all parties involved in the care networks of palliative care patients. The primary objective is to ensure a high quality of life and a well-supported end-of-life journey for both the patient and the family, accomplished through collaborative efforts involving all caregivers, whether they're paid professionals or unpaid individuals. So our approach, Dale, at Pallium is aligned with the vision and recommendations described by Kevin Brazil. It aims to educate healthcare professionals on the palliative care approach across different settings and professions so that all share a common understanding and language related to palliative care and all see opportunities for seamless care across different settings and across the illness trajectory, and initiating, of course, palliative care earlier. So it promotes interprofessional learning and collaboration. So again, focusing on only one sector or profession or disease group at a time, it won't lead to culture change, will it? Or system preparedness and system capacity that we know is desperately needed now. So our approach has been to build that primary or generalist level capacity, primarily through palliative care education and support materials to healthcare professionals who, in the course of their work, are involved in the care of patients with advanced cancer or non-cancer diseases. And that's what we call the palliative care approach. So by equipping them with these skills, Dale, They're able to identify patients much earlier who could benefit from the palliative care approach. It identifies their physical, social, psychological, and religious spiritual needs and begin to address them, engage them in a timely and effective advanced care planning and goals of care discussions. And it identifies patients with more complex needs who will require the intervention of a specialist palliative care team. So we view palliative care as being everyone's business, right? It translates practices and evidence, and then provides palliative care educators with tools, and in our case, our elite courseware and things such as the palliative pocketbook and apps to help them diffuse the palliative care.
So yeah, I mean, an important point I think that you make there that deserves perhaps more emphasis, which is that it's not. I mean, the palliative care approach is not a specialty, right, or done by specialists, right? It's done by everyone within healthcare, not necessarily to those that have been given perhaps a prognosis of death, but and then there is the specialty side of things as well.
Right.
Well,
both are needed, right?
Yep.
We're not trying to turn primary level or generous level, healthcare professionals into palliative care specialists. I mean, palliative care specialists are a critical component of delivery of proper palliative care, right? But the reality is everyone has a role to play.
So one of the other things that you mentioned, I just maybe come back to, and I know we may not want to turn this into a history lesson, but 10 years ago when the WHO sort of made that sort of proclamation is not long really in time. Do you have any insight in terms of what was the critical thing that sort of triggered that sort of to happen? Like why did the conversation shift, or why that conversation at that point in time?
Well, I think, all countries are coming to the reality of the fact that we're all facing an aging demographic, right? People are living longer. They're living with a number of comorbidities, right? So it's putting far more pressure on all healthcare systems around the world. And the reality is that we're not equipped to deal with this tsunami. And I think COVID has just given us a glimpse into what can happen when we're not prepared. So I think the World Health Organization, rightly so, back in 2014, went on record to say this is something that we all need to begin addressing. Every single country has more to do on this front end, and certainly Canada has a lot of work to do.
So yeah, I mean, that's about 6 years before our pandemic sort of begins. How did things change as a result of that? I mean, has the last 3.5 years altered the way we look at palliative care and approaching all of this?
It's interesting. A few days before the World Health Organization declared the novel coronavirus outbreak a pandemic, the critical importance of palliative care training was actually discussed by the House of Commons Health Committee, and a presentation was given by Kai that highlighted that 3 in 5 doctors do not feel ready to provide palliative care, despite 80% of them seeing patients who need it. And by not activating a palliative care approach themselves, many patients suffer needlessly through their illness, which in some times, Dale, can be many months or even years. It also leads to poor healthcare decisions and inappropriate and expensive use of healthcare resources. And this includes, very higher rates of hospitalizations, emergency departments, hospital deaths, which are a major drain on healthcare budgets. A recent national review by KPMG of palliative care in Australia actually concluded by saying that palliative care should be a major health system investment for the benefit it has not only on patients facing serious illness, but as well as the economy. So when the pandemic hit, palliative care became a critical issue for patients and families, and a hurried effort ensued, right, to increase palliative care capacity and for healthcare providers to acquire basic fundamental competencies during the pandemic for clinicians, who aren't familiar with this area but might be called upon to provide palliation. So this sudden demand created, a professional and healthcare crisis, underscoring the necessity to swiftly develop and distribute resources to assist them during the pandemic. So, amidst the emergence of COVID, there was a rapid transformation, as we know, in the protocols for administering palliative end of life care within the healthcare system, and the implementation, of course, of social isolation measures and limitations on visits and residences and hospitals and hospices and long-term care residents. Led, as we know, to patients, residents, and families being separated and grieving alone, and
Hmm.
frontline healthcare professionals assuming the role of primary and actually, Dale, in some cases, sole providers of palliative care support for patients. Unfortunately, during this critical period where proficient palliative care abilities were crucial, a significant number of carers lacked the necessary knowledge and attitudes and skills to fulfill the task, right? So it really did put a strain on resources. It exposed gaps and systemic vulnerabilities in palliative care delivery and supportive care more broadly across all settings in this country, right? Both in hospitals, not just long-term care, hospitals, as well as in home and community care settings. So, as a response, and in the face of these challenges and uncertainties, one of the things that we did at Pallium is we led a number of initiatives. And thanks to funding support received from the Canadian Medical Association, Health Canada, and these were initiatives really aimed, Dale, at enhancing training of frontline healthcare workers in essential palliative care skills. So there was a number of 25 webinars that we created. It resulted in some 14,000 healthcare professionals registering, 6,500 attending, and some 978 urban, rural, and remote, communities across Canada were represented, and some 30,000 views. So there was an appetite for this.
Hmm.
And what fell out of that, as a result of that and the uptake and the need for it, Health Canada ended up funding what we call the Palliative Care Record Project, right, which is a 5-year national initiative that cultivates communities of practice, right, and supports continuing professional development among healthcare professionals who care for patients with life-threatening illness. And it creates these virtual communities of learners by bringing together local healthcare providers and community leaders, and with regional, provincial, territorial, and national subject matter experts, right, to support continuous learning. So there's definitely been some positive outcomes for palliative care stemming from the pandemic. COVID has certainly shone the spotlight on the need for better palliative care. And frankly, as a sector, we cannot lose this opportunity to push for even broader change and greater funding.
Yeah, well, I mean, that's certainly one of the overused adages about crisis, about right these opportunities that come. But hopefully, it does shine the light on a gap and an opportunity for change. And I do commend you and Pallium for the work that, with the Echo project. I think it's really amazing and well named in terms of an opportunity for amplifying and spreading knowledge throughout the system. So hopefully maybe you can provide us with a link to that we can include in our show notes hereafter for people who want to learn more.
Absolutely.
Um, so I mean it may beg the question, I guess, a little bit in terms of what is why people can't access palliative care if it's something that's so obvious and has so many benefits, which is why aren't we making the investments that we're supposed to be, if that's the answer, but otherwise what is getting in the way of access?
I know we only have a certain amount of time to talk about this. Try to be succinct here. And I'd be remiss if I didn't start by recognizing that, listen, there has been some great progress in the last, say 20 years in terms of highlighting, and heightening awareness of palliative care and developing palliative care services. But the reality is, Dale, that Canada remains a patchwork with many gaps across the country in different jurisdictions, right? Some jurisdictions have one type of palliative care service or services, but not other essential ones. So obstacles, may arise for individuals across the country when it comes to accessing palliative care, regardless of whether they reside in densely populated urban areas or remote rural regions. And these challenges encompass various factors, including limitations in healthcare system capacity, insufficient awareness among healthcare professionals and the general public regarding the benefits of palliative care, geographic and demographic disparities in care provision. So by adopting a holistic, region-specific and culturally sensitive approach to palliative care, some of these obstacles can be overcome and thus ultimately enhancing accessibility. But there are a number of Canadian jurisdictions, although a number of them prioritize community palliative care. Only a small percentage of Canadians actually receive formal palliative care outside of hospitals and residential hospices. And Kai-Hai highlighted this, that while Canadians are living longer, their overall quality of life does not always improve. And
Mm-hmm.
life expectancy often brings with it, right, challenges of coping with poor health resulting from chronic illnesses, degenerative diseases, or cancer. So in addition to these factors, Canadians encounter other barriers when they're seeking palliative care, including difficulties accessing, essential medications when they're needed. So ensuring proper funding and establishing support systems to facilitate timely access and administration of medications are crucial aspects of overcoming this challenge. In addition, transitioning between provinces and territories can lead to interruptions in coverages and posing even further obstacles. So finally, the significance of culturally safe palliative care continues to grow, right, as we continue to strive to honor the cultural diversity
Mm-hmm.
of existing new Canadians. And I just want to finish by saying that the other barrier, Dale, is that palliative care has received inadequate attention in most medical and nursing school curricula, as well as college and university curricula for other healthcare professions. And while there were some important gains in a few medical schools as a result of projects such as the what we call FPEC, which is Educating Future Physicians on Palliative and End-of-Life Care. That was a competency-based model of medical education that was being integrated across the trajectory of medical education in Canada. It wasn't funded long enough, right, to ensure enough spread and scale in all the medical schools across the country and become truly entrenched. So some of the schools saw gains, but now they're experiencing cuts to the palliative care curriculum. So even at the postgraduate level, right, many residency programs in specialty areas such as internal medicine, cardiology, respirology, nephrology, critical care, they don't include palliative care training, even though they're going to be caring for patients with serious
Mm-hmm.
main illnesses, right? A recent study showed that only about 20 to 30% of internal medicine residents and only about 60% of family medicine residents are graduating with core palliative care skills. So they're not able to effectively activate a palliative care approach when they enter practice, right? So I could go on, but those are a few of the barriers that float to the top when you ask me that question.
Yeah, well, and I'm sure like you say, we could spend much more time on that. But I mean, I'm sure frustrating for those, who've dedicated their lives to palliative care to sort of trying to be, I guess, at some level, correct an absence of skills within the healthcare system amongst health professionals, only to see that we're continuing to graduate more that are still in the same boat. So, yeah.
Exactly right.
um, so I mean, you've touched on a lot of things that I mean, I appreciate you're talking about them in the context specific to palliative care. But taken out of that context would be some of the same concepts that we would be talking about um, our healthcare system, culture, people, more broadly speaking. You talk about cultural safety as an example of that. So, one of the other outcomes, I guess, of the pandemic has been, of course, our focus on our health workforce and our current crisis that we're in. So I'm wondering what you see as the connection between palliative care and discussions of our workforce more broadly.
Yeah. Yeah, well, I certainly do see a connection between palliative care and our HHR crisis. In fact, palliative care has experienced its own unique HHR challenges that I think provide some valuable lessons to inform plans to address this broader crisis. As I mentioned earlier in our conversation, it's important to understand that there are two levels of palliative care provision, right? There's primary or generalist level that's provided by by healthcare professionals who are not palliative care specialists, but with core palliative care competencies and are able to address the palliative care needs of many patients. And there's specialist level palliative care, which is provided by healthcare professionals with advanced palliative care training expertise.
Mm-hmm.
At the specialist palliative care level, there's a shortage of palliative care physicians with advanced palliative care training in this country. And there was a study done by Barbera, Klinger, and Pereira that identified 276 palliative care physicians in Ontario. And emerging standards call for at least double that number, right? It depends on the model you look at, but at least double that. So it's important to recognize the importance of both specialist level and primary level palliative care delivery and services. The two actually complement each other, and there should be close collaboration between specialist palliative care services and all other healthcare professionals and services. There should be adequately resourced specialist palliative care services like hospital or community consultation teams, palliative care units, and hospices. But with this drastic shortage of specialists, Dale, a system that relies primarily on specialist palliative care teams providing all palliative care, including primary level care, is unsustainable and ultimately reduces system capacity and access, particularly if we are to initiate palliative care, as we say, earlier and across all diagnoses. So, and this is described again by the World Health Assembly and the World Health Organization, the need for core palliative care competence across all fields, primary care and specialty areas will allow these professionals to initiate palliative care early. And there's many studies have identified the care of seriously ill persons and persons at the end of life as a challenging area of practice, right? Imagine being sent to work in an intensive care unit without the required skills. Imagine being asked to do something that is challenging without any training, right? You would feel, of course, anxious and stressed and probably by the end of the day exhausted. So it's a cause of significant distress for healthcare professionals who are often confronted with these situations on a daily basis, especially in some hospital, community, emergency, critical care, and long-term care services. We heard during the pandemic how healthcare professionals and other care providers and whole services struggled, to care for persons who were dying. It contributed to their burnout, right? Training makes a difference. We have heard many times, both anecdotally and during our studies exploring the impact of our training courses, LEAP courses, professionals saying that they feel training in this area makes them more confident. It makes them, enjoy providing this care more. It actually, many feel it's very satisfying work once they're trained in it. And some even describe the experience of joy in providing palliative care. And this last point, right, speaks to the fourth aim, the quadruple aim in quality improvement, which is about improving the experience of care providers.
Yeah, I fully agree. And we're going to do a few episodes on the podcast in the future on compassion fatigue, and the importance of all of that. So, I do think that you're talking about something that is critically important. And we certainly have been talking about that compassion fatigue, and moral distress that we certainly see within our workforce. And then yet, others would say that it's not a lack of compassion. It's not compassion itself isn't fatigued. It's our capabilities to,
That's right,
or capacity to deliver it, and the moral distress about not being able to do things that you would want to do or think you can do. So it's certainly a big, hairy problem. And I think, as you're describing, we're creating exponentially creating, I guess, a bottleneck of demand by not having the right resources throughout the system.
Well, that's right. And as my key message has been, as part of our discussion, has been, it's about building capacity with the resources we already have, right? That's a role to play. And I think that's absolutely correct.
So, one of the other areas that continues to come out of our conversations around health reform and reform of our health workforce, or transformation, is the question of scope of practice. What is your perspective on this? And maybe if you see that as part of the solution, maybe you can give some examples on what that might look like.
I'd love to. Yeah. So, for starters, and what you've gathered from what I've shared up to this point, right? Palliative care is a team sport, isn't it? It's
Hmm.
it's to be viewed as everyone's business. It's teamwork. It's leveraging everyone's skills and scopes of practice. Everyone has a role to play, of course. But I want to point to an example of three family health teams in Ontario. One was in Petawawa. One was at the Bruyere Family Health Team here in Ottawa, and the Jane Finch Health Team in Toronto.
Hmm.
Each of these family health teams identified a need to provide comprehensive care to their patients and communities under their care. Providing palliative care needed to be an inherent part of their plans. So they actually had all team members from physicians and nurses to social workers and pharmacists and even the administrative staff, Dale, undertake LEAP training. And they are now providing excellent primary level palliative care to their patients and communities. And they have access to specialist palliative care teams for the more complex cases, right? And for their quality improvement work. And similarly, several years ago, the Ontario Renal Network, which of course is the organization in Ontario that oversees the care of patients with kidney disease, realized that their entire teams needed core palliative care skills. So again, they partnered with us to make LEAP Renal available to all their team members.
So, I mean, that's, I think, very inspiring. And I think you're also, maybe in terms of the examples that you give about this actually happening, I guess, in family health as
Yes.
opposed to, um, specialties in our hospitals or even in hospice, right? So I think that perhaps speaks to some of where the opportunities may be. I mean, is there a reason, I guess, that you found those examples in particular?
Yeah, these were groups that had self-identified
Yeah.
and came to us with specific needs. So, but the reality is that when we talk about a systems approach, we could give you just as many examples in community care settings and hospital settings, and even among paramedic teams, which is a very interesting innovation that I'd love to speak to you about.
Sure. Well, if you'd like to share, go for it. So,
Well, all right. So this is really an interesting example because it's an innovative paramedic palliative care program that actually began in 2014. It was led by the provinces of Nova Scotia and Prince Edward Island and ourselves at Pallium. And the goal of the program, Dale, was to enhance the care provided by paramedics for patients receiving palliative care at home, who were, and they were often, right, the first responders in these situations. And we identified together five what we call our desired outcomes, right? So the first one was ultimately, of course, enhanced care provided by paramedics for patients receiving palliative care in the home. Secondly, it was to improve access to palliative care supports at home, regardless of location and time of day. Enhanced palliative end-of-life experience for patients and their families, reduced emergency department transfers, and improved paramedic competencies and confidence in provision of palliative care. So here was the situation at the time. Both provinces were experiencing very high rates of transfer from home to emergency departments when paramedics were called to the homes of patients with palliative care needs. So this was identified as an area for improvement.
hmm.
In addition, the paramedics had reported a lack of expertise and comfort in providing the palliative care approach, which was another opportunity for improvement. So all paramedics, 100% in both provinces, were trained over a period of 9 months. That's about 1,100 paramedics leveraging Pallium's LEAP paramedic course. And LEAP paramedic sessions were facilitated by local palliative care teams along with palliative care trained paramedics. And these facilitator teams all received our LEAP facilitator training. And it's interesting, there was a multi-pronged evaluation of the program that was undertaken. Surveys and interviews with patients, families, paramedics, and leads, and a return on investment analysis showed the following. 47% of EMS responses to patients with palliative goals of care result in the patient being able to remain at home, where we know they want to be. Significantly more patients were treated at home versus being transported to hospital. So in Nova Scotia, transports to hospital decreased from 59.2% to 47.6%. In PEI, which previously had a policy to transfer all patients to hospitals, paramedics treated 32% of patients requiring palliative care at home. So the estimated return on investment for the program was $2.5 million, and that includes the value of avoided emergency department visits, value of avoided hospital admissions, and the value of about 114 returned unit hours to the system. So there was slightly longer time on scene, but the overall time on task for EMS staff was lower compared to EMS events where transport occurred. So, and I think an important lesson, Dale, from this project is the impact that investing in scaling and spreading of an innovation can make. And I'd like to commend, CPAC, Community Partnership Against Cancer, in funding the continued rollout of the paramedic providing palliative care at home program. So instead of reinventing the wheel, right, and funding can go into spreading these proven initiatives into many other jurisdictions. And when this happens, what happens, Dale, is that you start to hit a tipping point, right, where where it takes hold and it starts to spread exponentially. It's just a normal part of the system.
Mhm.
This type of investment in scaling and spreading on a much broader scale, I think is needed beyond what CPAC is able to fund, so that other settings of care can benefit. And I'm talking long-term care, hospitals, and home and community.
Yeah, well, an impact culture, I think, is what you're describing ultimately, which, yeah. So, the pandemic certainly has us on the brink of a host of changes and improvements, and to our health system standards, regulatory, legislative changes, and not to make this Ontario specific, but I certainly that we both live here. They're making changes to the long-term care legislation that will obviously highlight palliative care even more than it did before. Um, so, I don't want to put you on the hot seat of being a political commentator here, and put you in the crosshairs of anyone or any government. But, in your perspective, do these changes, do they address the issues that you've raised at the outset? Is this getting us to the right place? And if not, what more needs to be done?
Yeah, no, that's a fair question. Um, so I'm going to actually start at the federal level, Dale,
Hmm.
because I think it's an important starting point because it has implications at the PT level. So, as you may recall, back in 2017, federal legislation set into motion, right, the development of a national palliative care framework. So, Bill C-277 called for better access to palliative care in community and home settings, including hospitals, long-term care facilities, and residential hospices. It also called on the federal government to work with the provinces and territories, as well as palliative care experts, to develop a structure that will guide and support the implementation of high quality palliative care services. So, in response to that legislation, and after extensive consultation with provinces and territories and experts and stakeholders, including people with lived experience, right across the country, Health Canada developed, as we know, the framework on palliative care, which was launched in 2018, and the corresponding action plan on palliative care, which was released a year later. And while certainly I acknowledge and express gratitude for the efforts and investments made by the federal government thus far, it is evidence that the government has not fully fulfilled the commitments outlined in the framework and action plan. And frankly, urgent action is necessary to effectively realize and pursue the objectives established in the framework and the action plan, and to respond, as I mentioned earlier, to the evolving demographics and other factors that demand increased availability and accessibility to palliative care services for individuals across the country. At the upcoming 5-year milestone in December of this year, it is the responsibility of the federal government to provide a comprehensive update on advancements made in implementing both the framework and the action plan of palliative care. So we strongly urge the government to take immediate and decisive measures to guarantee that every individual in Canada has equitable access to affordable, culturally sensitive, and exceptional palliative care services that, frankly, they rightly deserve. Now, in the bilateral health funding agreements between feds and the PTs, it's crucial to give paramount importance to enhancements and heighten investments in palliative care. And this can be accomplished by establishing dedicated funding for palliative care and implementing provisions that mandate public reporting on the outcomes resulting from this financial support. Let's switch gears now to Ontario. So in Ontario, to your original question, over the past few years, the government has certainly taken steps to address the barriers to improve access to palliative care in the province, right? And you may recall MPP Sam Oosterhoff's bill, the Compassionate Care Act, led to the development of a provincial palliative care framework. And the
Hmm.
framework, right, clearly identified the need to explore best practice models. For example, integrating palliative care training and education for interdisciplinary teams. We're also encouraged to see the passage of the Fixing the Long-Term Care Act, which mandated long-term care homes to ensure that residents receive care and services that integrate what they call a palliative care philosophy. We call it palliative care approach, but a palliative care philosophy. So it
Hmm.
ensures in legislation, right, a commitment that integration of palliative care be guaranteed to residents of Ontario's long-term care homes and other provinces are likely to take similar action, in my opinion. But what I'd like to see, again, kind of what we talked about earlier, Dale, is a commitment to scale and spread trusted evidence-based solutions to ensure that all healthcare professionals, including leadership, working in long-term care residents, have the skills and knowledge to provide exceptional palliative care. It's not enough just to build the homes or hospices. If the people working in these care facilities don't have the required skills, knowledge, and comfort level, then it's only half the equation, isn't it?
Well, and I think a lot of what you've described, the the common points or issues that we see in so many of our conversations about healthcare, I guess more broadly speaking, you're talking about issues about access, right? You're talking about quality, you're talking about affordability and sustainability. You're right, so. Um, yeah, I think that so many of the points that you've raised over the course of our conversation are things that we hear in so many other aspects, but this one particular topic or part of our care continuum, right, continues to sort of get short shrift, I guess, in terms of
Well,
that.
yeah, Dale, and I think it goes back to your original question off the top, which is palliative care has a brand issue, right?
Hmm.
It's not well understood. It's underfunded. In fact, I liken palliative care to where mental health and mental illness was 15, 20 years ago. Well, look how far that movement has come over the past decade and a half, 2 decades. And certainly more needs to be done. But, there's a few pages or a few chapters out of, that book that palliative care could be, leveraging as it moves its mission forward to ultimately provide better, earlier care to more Canadians.
Is it a stigma thing? I don't know if you could, if that's, I know we're trying to blend metaphors a little bit, but is it partly the same thing that mental health has faced over the years in terms of us not being able to talk about it because it was stigmatized in terms of our brains?
Good question. I think that's part of it. Let's face it, loss and mortality are inherent aspects of the human experience, right? But
Hmm.
our current obsession with finding cures and our fear of dying create obstacles, right, to providing, comprehensive person-centered palliative care. And these barriers often result in, the inefficient utilization of resources, right? So it's really essential, Dale, to normalize discussions around living with illness and the dying process and death and bereavement, right? Society equates palliative care with end of life care, right? The last weeks of life or the terminal phase, as we call it. Death is not a failure of medicine. It's an inevitable part of life. And to
Yeah.
not fully, I forget where I took that from. I borrowed that line from someone, but to not fully apply our capacity to reduce suffering is, however, a catastrophic failure of medicine, isn't it?
Yeah, well, I think you're right. We're focused on extending life, right? Without really acknowledging that life has an end, right? So let's make that whole quality of that process when we were born to die, right, as easy as it possibly can, whilst maximizing the life experience we have too, the joy and all of that. So it doesn't have to be either or. Um, so. I mean, I know we've talked on several of these kinds of things, over the course of this conversation, but you know, when we talk about so many kinds of large manifest changes within the health system that we're looking for, we're talking about changes in culture and mindset. Almost all of them come back to the question of leadership or the role of leadership in playing in that. So, from your perspective, where does leadership and leaders fit into this, and even from a learning perspective, given that we both have some skin in that game, where does that fit?
Right. Yeah, I mean, listen, the role of leaders in driving systems and culture change, of course, is of paramount importance. And I like to give examples of what I mean by this. So, um, as part of our research and our quality improvement work, one of the things that we undertake are pre and post surveys, with our learners, right? We also capture from each learner 3 to 5 commitments that they plan to put into practice and what they've learned from our lead courses. And we call these commitment to change.
Hmm.
And for those of you who aren't familiar with commitment to change, it's an approach to reinforce learning and encourage participation, and application to practice. So, as I said, immediately post course, learners commit to making changes in their practice as a result of participating in the course. So, these are the statements. And then several weeks or months later, our system automatically reaches out to them and prompts them to reflect on their commitments, right? Or what we call reflections. And there's been several studies, including many randomized trials that show that clinicians who express a commitment to change post-intervention and those who reflect on them at a later time are more likely to change their behavior and practice, right?
Hmm.
And increase the likelihood of follow through. So where am I going with this? We analyzed the 4-month post-course commitment to change reflections submitted by our learners. The most common implemented commitments relate to initiating palliative care early, which is great across disease, pain and symptom management, use of clinical instruments, advanced care planning, interprofessional collaboration. But the barriers were interesting. The barriers to implementation into practice include lack of time, no surprise, system level factors such as lack of support by their leaders,
Hmm.
untrained colleagues. So lack of support by their leaders were standing in the way of then implementing what they had learned. So leaders play a critical role in setting the direction, the vision, and values of an organization, right? They have the ability to influence and shape the behaviors and attitudes and norms within the system that they're responsible for. So they serve as the role models, don't they, for others? They bring people together around a common vision and they encourage alignment. They're accountable for driving change, right? So if our leaders aren't fully committed and supportive of the content and principles we're teaching, right, genuine and enduring transformation will not materialize. So we realized that we needed to develop a course that offers healthcare leaders, regardless of their level of leadership, a comprehensive range of knowledge, insights, and resources to enhance the palliative care aspects within their organizations. And so this course, Leap Leaders, was born, and it aims to foster a better understanding of palliative care and its impacts on patients and healthcare services, right? It covers, essential, components required for effective palliative care service planning, data, evidence to support this. It's going to assist leaders in evaluating their existing services and guide them in developing business plans and initiatives that promote the seamless integration or endorsement of palliative care for the patients with serious illness. And this was launched about a year ago, so we're very anxious to measure the results and impact. So hopefully we can circle back at a future point, and I'll share with you how
Yeah,
that's.
that would be very interesting. But I mean, I mean, to sum that up, I mean, leaders have a great capacity or to be enablers for system change and adoption. Failure to be enablers, they will be obstacles.
Absolutely, absolutely, right?
So,
So they invest all this time, energy, and resources in building capacity among their staff, and in many cases, they're the barrier that stands between them and implementing what they've learned to ultimately provide better care to patients. So
yeah, well,
this
I
is why
mean,
the systems approach is so important. It can't just be about the healthcare professionals or the community. It has to be the leadership, right, and the public health policymakers and the health policymakers. So it
yeah,
truly is a systems approach.
yeah, to provide them the resources, make sure that other things that are in the way are removed, and to make it a priority. Um, so it's been a a wonderful conversation, Jeff. I've enjoyed this, and I'm sure we could talk about this in so many other aspects. But in the interest of time, I mean, last words to you in terms of anything else that you'd like to share that hasn't been covered, and maybe I will also ask you just as another thought. I mean, I know healthcare loves acronyms, and you've used the word LEAP throughout. Maybe just for our learners or our listeners here, sorry, define what that is and maybe where they can learn more about that too.
Yeah, sure. So I'll start with that. I'll start with your second question first. So LEAP is an acronym. It actually works in both French and English. So LEAP stands for Learning Essential Approaches to Palliative Care, or in French, Les Essentiels de l'Approche Palliative. So that's why we call it LEAP. And last words. Yeah. So listen, I think we've reached a crucial juncture, right? That demands uh, a comprehensive, a system-wide solution, and to our last point, resolute leadership that goes beyond. It goes beyond the incremental measures and minor adjustments, instead focusing on genuine transformative change, right? And drawing lessons from the COVID-19 pandemic, which is still very fresh in everyone's mind. It's imperative that we acknowledge the deficiency in core palliative care competencies among many healthcare and human resource providers, right? And I think, we have to honor the memory of those who received inadequate palliative care and passed away by committing the necessary resources to establish widespread and purposeful implementation of consistent education standards and training. This step, I think, is vital to ensure that basic palliative care is consistently delivered and to prevent such lapses in the future.
Yeah. So truly, I mean, the quality of healthcare and quality of life depends on it. So, well, again, thank you very much, Jeff, for taking the time to have this conversation with me today. And yes, I wish you best of well, and look forward to future conversations on this and the research and findings that you continue to get.
Dale, thank you very much for the opportunity to speak with you today. I really appreciate it.
Okay, take care. You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.